Hello, everyone. Welcome to Harvard Medical School. I'm Jeff Flyer, Dean of Harvard Medical School, and we're really pleased to be participating in HUBweek, which celebrates the unique confluence of art and science and technology that really is the hallmark of the Boston area and the broader region. It's fitting that we're gathered for this meeting today in the new research building. That's what we call this place. Just upstairs, our geneticists, immunologists, microbiologists, and many other scientists are working to understand the fundamental causes, the means of prevention, and ultimately the treatment and eradication of disease. This is really curiosity-driven science in one sense. Art, science, and technology collide every day in these laboratories where our faculty, our postdocs, students are working to unravel the most complex healthcare questions and challenges of our time. So today, we're here to discuss the power and promise of precision medicine, a topic that has blanketed the news for the last several years and will continue to be widely present in the news. So what really is precision medicine? Who will have access to it? Who's going to pay for it? And how will it affect patient lives and patient privacy? I really cannot imagine any better speakers to address these important questions than the people we have here today, Professors George Church and Zach Kohane. George Church is the Robert Winthrop Professor of Genetics at Harvard Medical School. He's a founding member of the Wyss Institute for Biologically Inspired Engineering at Harvard and director of the National Institutes of Health Center for Excellence in Genomic Sciences. He also founded the Personal Genome Project, the world's only open access information on human genetic, environmental, and trait data. George is known for many things, not only for his TED Talks and his appearances on the Colbert Report, but for pioneering the specialized fields of personal genomics and synthetic biology. Zach Kohane is the inaugural chair of the Harvard Medical School Department of Biomedical Informatics, whose mission it is to develop the methods, the tools, the infrastructure for a new generation of medical investigators and care providers to take really full advantage of the insights and precision offered by these enormous data resources. Zach leads 3 very large NIH-funded projects, including he's the coordinating center for the Undiagnosed Disease Network, the Center for Excellence in Genomic Science, and in Big Data to Knowledge. Our spirited, and I know it will be spirited, discussion will be moderated by Martha Bebinger, an acclaimed healthcare and general assignment reporter for BUR, who I hear almost every morning on my ride into Harvard Medical School. She also created and contributes frequently to Healthcare Savvy, WBUR's community of patients shopping for healthcare. Martha is the recipient of numerous awards herself, including being named a Nieman Fellow at Harvard University in 2010, and she's really a Boston treasure that we value, and we're very glad that she agreed to participate in this discussion. So we'll turn it over to these 3 individuals, and I hope you enjoy the session. Thank you.
Thank you so much, Dean. We're going to open the window on this exciting world of precision medicine just between the 3 of us for about 30 minutes, and then we'll turn to you for your brilliant questions. If you're tweeting the hashtag HUBweek, we'll get you into the conversation about all the exciting things that are happening around that event in Boston this week. So, first of all, George, if you were to run into your 3rd grade teacher at the grocery store, and she recognized you, and she said, "I'm hearing a lot about this thing, precision medicine. What is it?" What are you going to tell her?
So, I don't think she'd recognize me, but anyway, I would say that this is what's going to make us all healthier and live longer, youthful lives, vitality, more than just absence of sickness, and it's going to do it by measuring much more than we've ever measured. Everything about us that could possibly have impact, ranging from our social networks to our microbiome to our genome and so forth. And that's that big data that we used to be scared of. It used to be that you would measure as little as possible if you were a physician. And now I think we're aiming towards a time where, from the president on down, we're pretty excited about measuring as much as possible.
Is it reasonable to think that there are 3 components, the genome, the environment, and our lifestyle, or do you not think of it that way?
I can think of it that way. That's close enough, yeah.
Okay,
Yeah.
all right. Zach, in this world, did you have a oh my God moment? Did you have a point where you thought, this is where we're headed? I never thought I'd see it.
Actually, it's more like I had a drawn-out, oh my God moment for 30 years. Oh my God, why are we not doing the following? And so for those of us who use the web, I'll give this metaphor.
It started 30 years ago?
His moment.
Your moment started
my
30 years
moment,
ago.
yeah.
Wow.
Yeah, so I was recently minted as a PhD in computer science. I was back into medical school, and I learned about all these techniques for categorizing individuals, classifying them, and automating the diagnosis. And then I saw a very much more artisanal thing that was happening in medicine. And the oh my gosh was, oh my gosh, why was the stuff that we were doing in computer science not being applied to medicine? And let me be very concrete. Today, in Netflix, when you order up what they recommend you to watch, they know your entire history of what you've watched. They know the entire history of what everybody else has watched. They're aware of all the history of everybody else who's had similar histories to you and what they watched, and therefore they can predict with high accuracy those movies you're going to like. With most primary care today, unfortunately, the doctor is not going to know most of your past history, and will keep asking the same questions again and again. They're not going to know, certainly, all the patients in the world like you. They'll be lucky if they remember all the details about all the patients like you. And in Netflix, they wanted a better recommender. What did they do? They made all their data available for contests for people to improve the Netflix recommendation engine. We have the data. We have never made it available to allow us to, now back to precision medicine, to precisely stratify based on all the data that George alluded to. Precisely say, you're this kind of person who's going to respond to these medications in the following manner, and these are the likely clinical courses that you have. So the oh my gosh is, oh my gosh, why 2015?
So what's the answer?
The answer is medicine is A, a very conservative practice. B, there are societal and institutional barriers deeply grounded in human behavior that prevent the kind of data sharing that we need to have. And 3, some of the most important data, the genomic data, was not available at scale and at a reasonable cost until very recently.
So we're starting to surmount some of those issues, right? A couple of examples, George?
Well, the last one, cost, has plummeted from $3 billion human genome now to a $1,000 genome complete with genetic counseling. So I think that that can influence the other ones as well in a sort of a virtuous cycle. But I think all of those things, even the deeply ingrained things, are subject to change.
So if folks out here are ready to do that $1,000 sequencing and counseling,
Yeah.
they then, though, have to go to the primary care doctor they've been seeing
Yeah.
for a very long time.
Yeah.
Isn't there a huge gap between what that person will likely understand about using the data and
I don't think there's a much, yes, simple answer is yes, there's a gap, but it's not any worse than the gap that your primary care physician has to many other specialties, and that's why you get referred so easily to other specialties. This one is a bigger gap because, maybe, but there is already awesome software and there growing means of education, I think, is the solution. But you're going to get referred to a specialist.
I think that George is right. And the problem is
right on you'll get referred to a specialist or right on the
right on the referral to specialist right now. Because right now, it turns out that the least paid individuals, among the least paid individuals in the healthcare system, know the most about genomics, except for a small group of doctors. And those are the genetic counselors. So genetic counselors actually know about probabilities and genetics and and how those translate into decisions more than most doctors. They're paid order of magnitude less than most doctors. And then there's a small group of doctors who know how to do this. It doesn't have to be this way. We have a great counterexample. There's a technology that involves literally gigabytes of data that gets massaged by computers in real time, and a metaphor is generated that is a very usable metaphor by most doctors. I'm talking about MRIs. So MRIs take vast amounts of data in seconds, deconvolute all that data, and create an image that a doctor can understand. And we haven't quite achieved that in medicine, which is to create that machine, which takes all that data and resolves it into something that doctors can understand and make a recommendation on. And what that means, though, is if this pertains to the general practice of medicine, which we believe it does, that means that this kind of decision support will be a much more integral part to physician practice, as opposed to our sometimes hubristic thought that we're going to be able to maintain all these dependencies in our head.
So this is kind of a cart and horse issue, right? I mean, do we wait? Do we say to these folks, don't go get the test yet because we don't really know how to manage all that data? Or is it time for everybody to go start getting the test and then we'll have the data?
It all depends, in my view, I'll be curious to hear George's view, in how deep trouble are you right now? So if you're in deep trouble because you have a child who has not responded to, let's say with inflammatory bowel disease, to all the therapies, has had surgery, I think it's a completely reasonable thing to do, to say, I want to get sequencing, I want to get transcriptome, I want to get epigenome, and have the best minds working on it. If you're doing all right, and the current therapies seem to be working, perhaps you can wait. Or if you're very curious, maybe not. But I think the decision moment really comes when you've got a problem that is not being answered by conventional medicine using the standard available data.
So 1 second, George, just to clarify. So the average healthy patient doesn't need to think about having their
Well,
genomes.
I'm sure George will disagree with me on this one. But I think the short answer is, and he and I have had very pleasant back and forths around this, the problem is we actually don't know what most of the genome means. And so if you're otherwise healthy, there's a lot of scary stories buried in that, potentially scary stories that are incorrect, buried in that. Let me try to make this vivid. I don't know if those of you remember, about 10 years ago, you could hear on the radio, for your birthday, for your loved one, give a whole body CAT scan to your loved one. Well, guess what you get when you get a whole body CAT scan? Anybody my age, let's say, you're riddled with little small tumors. 30% of us have little tumors on our pituitary gland that you will never affect you and you will die with. But if I know about it, we're going to end up referring you. You might actually even have to see a surgical knife. But it's irrelevant.
For no benefit.
We don't, until the day that we have massive, massive data, these genomes of everybody, I'm going to claim that maybe it's interesting. You can get a lot of genealogy. But unless you're sick, I think I wouldn't worry about it that much. But George is going to disagree with me.
Yeah, in a very supportive way.
Yes.
So I think that MRI does require a specialist, even though it's got this awesome software that makes it possible for the specialist to see it. And we do have awesome software for genetics. Zach and I are involved in some of that, so he's being modest. That's maybe close enough for genetic counselors to practice on people who not just are severely affected, but are carriers. So let's say you're perfectly healthy, but you're a carrier for a serious disease and you're getting ready to date, marry, have a child, any of those stages. It matters. It matters quite a bit. And there are thousands of diseases which we're all at risk for being carriers of. And even though they are individually rare, they are collectively common in our society, somewhere between 1% and 10%. People are very severely affected by these recessive, typically, diseases. So that's one example of where you're healthy and there's something you can do right away. And this applies to 100% of the population until you get the information. Then you can say, well, it didn't apply to me, but you didn't know that in advance. The second category is if you have a predisposition to certain actionable adult onset things, like cancers. There's a handful of cancers where if patients have it, they will remove the at-risk body parts and probably and reduce their risk. Now, this is best done in a family history situation, but it is migrating to a case where the whole population can be considered.
Can we just name those real quickly?
And the most famous, go ahead.
Just name those real quickly.
So, for example, breast, ovarian, stomach, and colon cancer.
Those are the people who should think about having their sequence. Okay.
Well, everybody should think about it because everybody's at risk for all of those. Okay.
Okay.
It's a matter of transition as to where we are along whether you've had family history or not, because many people are the first person in their family to get it. So does that mean that we should bias the medical system against them just because it's rare? These things are individually rare but collectively common, and the poster child, the big aha moment was Angelina Jolie, who her physician said that she had an 87% risk based on her genetic test before she had surgery and a 5% after surgery. So this is something that probably a lot of people should know. And if they find out that they didn't have, they get the test and they find out they didn't have it, that's great. That's great news.
So George and I agree on 95% of things, but this is the 5% that we disagree on. But I think that's probably entertaining and illuminating. So I think the Angelina Jolie case is actually very good to dwell on, because I was looking at a large, with a colleague of mine, at a large insurance database. And shortly after she wrote the editorial in the op-ed piece in the New York Times, this is what happened to the rate of ordering a BRCA test. By the way, doctors hadn't gotten smarter.
Do you know how many people that was?
Thousands. Thousands. And it was, I think, about a 15% increase. And here's the thing. In 6 months, the number of bilateral mastectomies also took a big jump up. But here's the more important point. I can also tell you that papers, publications, which show several cohorts of women who've had bilateral mastectomies and oophorectomies for BRCA mutations that now we know 10 years later have no clinical meaning. And so there's a issue, which is just having the statistics right. And BRCA is one of the best studied genes. And we have 20,000 other genes that we have to study, and we don't have yet good population frequencies on those. And so the risk to get body parts removed unnecessarily is substantial. And we've all seen that, and the medical profession is conflicted, because under the spirit of biomarker or biomark up, if you have a marker that says you can now do a surgical procedure, all sorts of crazy incentives go into play. And so we saw with the prostate-specific antigen, which is useful in one context, how it could be misused if you didn't know the right comparison population. And we're going to have this in spades with genomics. It's not to say that George is wrong. It's going to be, as we have more and more big data about the rest of us in our natural state, we're going to be able to be much more precise about the risk. But right now, we're in this little messy interregnum between having genomes on a few people, just a few thousand people, and genomes on most people.
So how long are we going to be in the messy space?
Not that long. George, how long do you think it's going to take until we have a quarter of our population genome sequenced?
Well, we've removed one of the biggest barriers, which was cost. The next biggest barrier is education. People don't realize how valuable it can be, even with the 5% difference we have here, which I would now, based on what Zach just said, I would lower it down to 1% difference.
Like that? The
fact is, there are things that are actionable. And even if there's one thing that's actionable on the population scale, because the cost is so low now, that merits everybody getting sequenced.
The cost is less than that of an MRI.
Well, right, but so you're measuring the cost of the sequencing. You're not measuring the cost of all those procedures that followed it.
Correct.
Right?
But you can get expert advice. Many people would prefer to have the procedure, even if it's useless. It has its own risk. But anyway, that's a separate, yes, there are costs to that, but only a fraction of the people who get tested are going to go on and take subsequent tests or monitor themselves more carefully or have surgeries. It is a risk. I fully agree with Zach on that. But it's only for certain things. And many of the people who had the unnecessary surgeries, that's because they were using methodology that started in 1991. The people who are getting it today are getting much better. The number of variants of unknown significance and modifier genes is much lower. So Zach's right, but it's dated and it's changing rapidly.
I think we'd be really performing a poor public service if we didn't say the following. George's example of prenatal testing is really important. And in fact, we can point to the Ashkenazi Jews as this weird population that has committed auto-eugenics over the last 30 years by essentially reducing the prevalence of Tay-Sachs by an order of magnitude by predating. It is very unusual that people tell me It's very unusual that people tell me I don't speak loudly enough.
It's very sad, yeah.
You might want to put it on the other side, maybe. Can you do that?
Better? All right. Oh, okay. So I just said that the prenatal testing case is really important, and we've seen in the Ashkenazi Jewish population, they've been able to reduce the frequency of Tay-Sachs by an order of magnitude just by doing the kind of testing that George has said. But another area which actually works well is today cancer. And if today you have, unfortunate to have you or a family member with cancer, for many, many of those cases, you can have a different therapy based on that understanding. So that's not presymptomatic testing or asymptomatic. It's testing, and it's not only testing your genome, it's testing the genome of your tumor, which is actually turns out multiple tumors, multiple genomes. But that, we're seeing increasingly, makes substantive difference to individuals. And then the third category that we've seen is children with, or people with unknown diseases. And there we've seen through things like the undiagnosed disease network, breakthrough cases. Those of you who may have read about Matt Might's case in the New Yorker, where he had a child who had seizures, developmental delay, multiple diagnoses that were all ultimately wrong, but by virtue of doing whole exome sequencing, diagnosis was made. And although at the end of the New Yorker article, you were left with the impression that this was a father who had a child in a tough shape and had made the diagnosis but had no therapy, we're missing the fact that as we learned at the Precision Medicine Conference here last June, he's actually gone on to actually take those precision medicine insights and found a therapy for his child, which has actually eliminated those seizures. So for those three categories, prenatal, cancer, and undiagnosed or rare diseases, it's breakthrough. It's making a huge difference even today.
So, sorry, did you want to jump in on something there?
Well, I was just going to. I realized I hadn't answered his question about when the 25% occurs, and I wasn't trying to evade it. And I don't know the answer, but we have a tipping point situation. It would be like asking me in 1993, when is everybody going to, or when is 25% of the population going to get a computer? Well, as soon as they learn about the World Wide Web, it was a purely educational process that occurred over the period of about 12 months, and suddenly it went from nobody being excited about computers to everybody being excited about it, and it's kept growing. And I think we're at that point right now where people are just, all they really need is one reason and a low enough price, and they will do it, and then they'll discover there were thousands of reasons. But all they need is one that we can clearly communicate and where we don't have to say, oh, well, there's a 5% difference between us, where we can all kind of, enough of us agree that it happens. And I think we're at that tipping point right now.
But aren't there some real lingering concerns about privacy? No?
Certainly, there's issues about privacy, but
I mean that are keeping people back, that are
I don't
asking people to pause.
I sincerely don't think that's what's holding people back.
Okay.
I think it is an issue, and we need to be very thoughtful about it. But I think what has been holding people back is cost and communication of value. For example, and very often it's the opposite, where if they have a serious disease, they want to share that information, and they want to get a lot of people working on it in the world, and they find barriers again and again. They can't take their health records from 2 institutions, get them together, and get them to a researcher. And so at this meeting that Zach was just referring to, we had a lot of patient advocates there their children were on what's called a genetic odyssey, and they were frustrated, not by the lack of privacy, but by the lack of sharing among the silos.
So I'd like to add to that. So George is right. Anybody who's been unfortunately afflicted with the disease, a vast, vast majority have no such concern. And then there's a group of individuals who don't have a disease, and there it's a bit more of a spectrum. But in reality, I think if people understood how much of their privacy has already been dissipated by existing medical sharing, as difficult as it is for you to get your electronic medical record from an institution, it is so easy for the commercial interests, like insurers and various other companies, to get to that same data. I think if people realized how much of their data has already been shared, they would be, even those who have concerns about it would be less concerned. Yeah. And I think there's this issue of destigmatization and the acknowledgement that although genetics is informative for the future, it's not determining.
In fact, the whole point of precision medicine is to escape what would have been destiny of our ancestors. I think an analogy to what Zach just said is the way that our credit ratings used to be. Lots of companies could get access to our credit ratings, but we couldn't. That wasn't the way to run credit ratings, and it's probably not the way to be running personal health records as well.
So, no, go ahead. Well, if you stay with that example for a minute, though, we put a lot of data out, and then we put some rules in place. So what do either regulators or government officials of some kind, maybe it's insurance companies or the healthcare community, what do they need to be thinking about guidelines for?
Well, first of all, one very important guideline is the Genetic Information Non-Discrimination Act of 2008, which prevents health insurers and employers from discriminating. Now,
that's enough?
Not at all, because there are loopholes. So there's life insurance, there's military, there's plain old discrimination that can occur in everyday life that isn't legislated, and there's probably going to be people who actually break the law as well. But that's an example of regulation that shows where the American peoples and their representatives are, in particular because there were very, very few cases of actual discrimination when that law was passed. So that sent a very strong signal out to all would-be discriminators that doing it on the basis of genetics is probably not a good idea.
So there's now a new common rule that's about to be enacted, and I think it makes the most important point, which is you need truly informed consent. And I think that what we have to do is enable our institutions to technologically implement means for patients to give that informed consent. So, as perhaps inadequate as it is, Facebook and Google give us ways to opt in and out of different levels of disclosure. There's no such scalable technology yet in healthcare, although it would not be difficult to make it happen. And so we have a common rule now which says if you want to disseminate data for this purpose or that purpose, particularly for research, you're going to have an explicit consent. I think ultimately the consent of the patient or proxy is the cure-all, because that's what we want as a society. The question is, we don't yet, unfortunately, have infrastructure to scale that, but that's something that could be fixed very readily.
We have prototypes.
Yeah.
Where you don't just hand them a consent form written by lawyers for lawyers, but something like a simple test where they can demonstrate their knowledge.
The Apple Research Kit, for example, does exactly that.
We're going to go to you guys after this next question. There are 4 mics around. So if you could start raising your hands and just getting the mics in place, then we will be able to move smoothly into that. As you ask a question, I'd ask that you introduce yourself and try to keep your question succinct if you could. Just a little bit more on cost, because I hear vast estimates about how much this will save, and then I hear health economists saying, no, the drug companies are just going to hike the cost of these individualized medicines. You know, they're going to give orphan status to everything, and we'll be in big trouble for a long time. Where do you fall on that?
I think we're going to be in big trouble for a short time.
Yeah.
I think that the most personalized drugs are indeed expensive. So that they just passed the first gene therapy in Europe, $1.6 million per dose, making it the most expensive drug in history. But I think these costs will come down, and there will be alternatives. We've certainly seen a gigantic reduction in price of the diagnostics, which there was no particular reason in advance to expect that.
But let's deal with a very hard case. Cancer. There are now some breakthrough immune therapies, which genuinely, if you have a loved one treating, it's going from death sentence to either long-term remission or cure. And if you had the money, you might not begrudge paying $100,000 a year to keep your loved one alive. Obviously, not everybody has $100,000. And if the promise of precision medicine comes true, it's not that small sliver of patients for which we have a drug that will qualify. It'll be all the full pie of patients who have cancer. But then, if you just scaled up that $100,000 a year, it'd be bigger than the United States gross national product. So we know that can't happen. And so market forces are going to have to intervene. And by the way, we saw some recent stories. You don't need precision medicine for drug prices to go up. What you need is an efficient market to keep them down. And so I think what we'll see is that the business model of therapeutics will have to change because we cannot afford to scale that $100,000 a year life-saving drug to all cancers.
Have to change how?
We're going to have to change it because we're going to have to reduce the regulatory overhead of getting approval, and we're also going to have to open up to a much larger marketplace so you can actually choose and compete. And
stratification is our friend here because if you break the population up into fairly large groups, then you end up with higher safety and efficacy on the first trial, and you can get smaller cohorts and faster approval and fewer adverse events.
Thank you very much to Harvard Med School, to the gentleman here, and to HUBweek.
Thank you, Martha.
Yep.